Hello, folks. Thanks for joining us on Head Inside Mental Health, featuring conversations about mental health and substance use treatment with experts, advocates, and professionals from across the country, sharing their thoughts and insights on the world of behavioral health care. Broadcasting on WPVM 1037, The Voice of Asheville, independent commercial-free radio. I'm Todd Weatherly, your host, therapeutic consultant and behavioral health expert. It's my pleasure today to welcome back to the show author of You Need Help, a step-by-step plan to convince a loved one to get counseling, Dr. Mark Komrad. Dr. Komrad appears widely on TV, radio, and podcast to discuss topics of psychiatry. He has been the host of a nationally syndicated weekly call-in radio talk show about psychiatry, Komrad on Call, and regularly appeared on the medical talk show Sunday Rounds, a call-in show broadcast to over 40 million listeners around the world. Dr. Komrad was elected by his peers to the prestigious American College of Psychiatrists and named as a distinguished fellow of the American Psychiatric Association. He's also voted one of Maryland's top mental health practitioners by Baltimore Magazine, as well as one of the top doctors in Baltimore. He earned his MD at Duke Medical School and trained in internal medicine and psychiatry at Johns Hopkins, where he is on the teaching faculty. He is also clinical assistant professor of psychiatry at the University of Maryland, Tulane, and LSU. He was an attending psychiatrist in the treatment-resistant psychotic disorders unit at Sheppard Pratt Hospital for 15 years, where he continues to train residents in psychotherapy and psychopharmacology. Dr. Komrad, welcome back to the show.
Thank you. Thank you so much.
I've sent your book to many of my clients. So here's a good question that fits into the middle of some of this I'd love to hear your answer about, which is, You've got folks that their level of acuity is pretty high. You know, they're having a lot of symptoms and everything else. And one question you'll get, but they're maybe not in the hospital yet. They're having symptoms, they're having delusions, they might even be having some psychosis, but they're sitting in the living room watching TV, trying to calm down, doing PRNs of some kind of medication that's keeping them calm for the moment, but it comes and goes. And so parents will ask me, I just today got asked this question, is there a way for us to do this in an outpatient setting? My answer is typically, it's a risk. I don't want to say no to things. There have been times when it's been successful, but moreover, residential environments are far more effective at med management and stabilization and so on and so forth. What's your answer to that question as a psychiatrist?
I think it depends on how much the treatment intensity can be flexible and dial up. So, for example, sometimes my goal always with my patients is to try to minimize hospitalization. And so there are many ways that I do that involve increasing my treatment intensity. So for some people, I may have to see them several times a week. Sometimes in a really acute situation, I may see people every single day. A couple of times in my career, I've been known to see people twice a day in the course of a day. Telephone contact. These days, of course, you can have telehealth contact as well. So all of those are methods by which, if a clinician is willing and available, which is a whole other discussion, to be able to increase and titrate up what a clinician can do in that kind of a setting. And of course, I may be making med changes every day under those kind of circumstances. So it's kind of an intensive outpatient paradigm. Then, of course, we have IOP centers and day treatment centers where people go at least 5 days a week for 4 to 6 hours at a time in a group setting. That's a hospital-like setting, except you don't spend the night in the hospital. You come back each morning and you go home each afternoon, and they get not just the attention of an individual psychiatrist there, but they get group therapy and nursing and so forth. And that's often a very reasonable intermediate way of dealing with unstable and acute situations.
And when I see somebody like that, I'll ask them to, maybe you should get a companion or somebody, at least for the first little while, to just give you some support at night. But
right. Well, if that's necessary, if that's possible, it depends. I mean, look, if somebody is having, great deal of difficulty making it through the night, most you have to have a certain level of psychological sophistication and experience in dealing with people who are so acutely uh, symptomatic from psychiatric disorders to be able to be a companion. Uh, and I think that in general, just having somebody sit with them who may not really understand illness, know what to say, that doesn't have any clinical training at all, even if it's training on the level of, peer support specialist, which is a whole training level itself for a mental health coach. Um, Sometimes that's insufficient. And it's tricky when you're dealing with overnight problems. That's generally an indication that you're ready for an inpatient level of intensity.
Well, and a
You
lot
know,
of times it's parents doing this role, of
right.
course, you know.
And that's exhausting. And, the thing about, say, inpatient uh, treatment is you've got shifts. So, staff put in 8-hour shifts so that they're refreshed and they're not exhausted. And sometimes, it takes 3 shifts of support and attention
Right.
to be able to get somebody through the night and through several days as well. So I think once you're getting into that level, it may well be that this sort of intensive outpatient approach, whether it's in an individual office or in a partial hospital, day hospital setting, uh, may not be sufficient. So
Yeah.
now to go back to the issue of what constitutes success. In other words, what would be progressive goals in the course of treatment? So as you get beyond the acute phase into sort of the subacute phase, if you will, um, which is where things are no longer extremely unstable, but a person is still symptomatic. Uh, the goals become first rather close to home to reestablish a person's capacity for self-care and some reasonable degree of independence. So their activities of daily living, hygiene, diet, sleep, um, and the ability to be able to have at least some basic levels of interaction with other people that are effective and meaningful are, more subacute goals. And
Right.
once you can establish that, because so that's a level of success in that phase. Now,
And
going for
sobriety. That's the other one that seems to
sobriety,
pop up for me is sobriety.
yeah,
Yeah.
absolutely, sobriety. So, which brings us to the idea of being able, in a sustained way, to put the things into your body that you need, such as diet, medications, so forth, and to stop putting into your body things that you don't need, like alcohol, other substances, and so forth. So, to be able to maintain some equilibrium between things that are needed and things that are not needed as a level of self care is, a very important subacute goal at that point.
Right.
Then, as we go out further, then we start to think about uh,
It's our time mark now, you think? Like if you were to give it a general average, you go out further past this subacute
right.
level
So
of
I
care.
would say several weeks, several
Okay.
weeks. Um, then we start to get into the issue. Let's say between 3 and 6, 3 and 8 weeks. Okay. Then we start to look at goals that I would call reintegration. Reintegration into the worlds of the two worlds in which Freud originally said we all have to function, which is the world of work and the world of love, both of them defined broadly. Um, right? The world of productive contributory activity, whether that's around the house or outside of the house, and the world of interpersonal relationships with people that care about you and people you care about. So reintegration would involve things like if a person has been so ill that they have to stop school, right? getting them back into class, stop work, getting them back into work. And it may be a part-time thing at first. Uh, Sometimes you may have to take off a fair amount of time. Sometimes it's longer than 8 weeks. But getting back into being a participant in the environment in which you live, whether that's your family or uh, your family of origin, your family that you've created with a spouse or significant other, care for others, not just care for yourself, whether that be children or a spouse or a parent that requires care, return to work, and gradually also returning to any avocational interests or vocational interests. By the way, that could be volunteer work.
Right.
That could be, hobbies and pastimes. Um, Something, even as simple as, the capacity to read books again, to keep up with the news again. So that is sort of the reintegration phase. And there we may be talking about some months. Again, if all is going well, if the treatment relationship is sustained, the treatment plan is sustained, both the things that you should be putting into your body and the things you shouldn't be putting into your body and so forth. So then after so that's a success there. Then in the much longer term or much longer term goals that people have in their lives, goals that may take months or some years to be able to achieve, to be able to mount a life that's a full, meaningful life with things such as building a career, taking a training course, or going to school and getting a degree, and graduating and being able to get into the job market and develop a career, developing significant relationships with developing circles of friends and maintaining circles of friends. Obviously, different people can achieve different amounts of these things, but these are certainly, at least this is the domain of goals that we're talking about. It includes these different things, being able to have a significant adult relationship if you're an adult, of an intimate relationship, develop a family if that's one of the goals that you have in your life, and to really maximize independence. And if you haven't already achieved it, in which case it would be rehabilitation, like, say, for example, being able to drive. If you had been able to drive, and by virtue of being acutely ill, you've lost the ability to drive, then regaining the ability to drive would be a rehabilitation. Achieving things that you've not achieved before in your life goals, maybe because you haven't been alive long enough, or because your illness has derailed you from achieving those, such as getting your driver's license for the first time, such as going to college for the first time, such as starting to date for the first time, that those would be called habilitation, as opposed to still do rehabilitation. So the habilitation goals are, in that sort of final phase, or, at the top of the pyramid. And a lot of those things involve self-sufficiency and independence. Of course, all of these are ideals, right? But frankly, in my work as a psychiatrist, the way I practice is I am thinking in terms of all of those different levels, and I am taking the journey with my patient. I mean, at this point, I've been in practice for 35 years, 36 years. So I have, there are a number of patients that we're growing old together, and how long we're going to be together is going to depend on which of us dies first. But so I've seen patients now through all of these different phases, some more robustly than others. And each person's success, of course, has to be reckoned in terms of the nature of their particular illness, their resources, their limitations, and so forth. Not necessarily everybody is going to want or even be able to achieve, I don't know, the college degree and things like that. But I'm always thinking when I settle in with a patient, it's not, okay, I'm here to treat your symptoms. And once we minimize your symptoms, we're done. Or once we minimize your symptoms, you can come back and see me, twice a year so I can make sure your symptoms remain minimized and we don't have to make any changes. And we'll sit together for a half an hour, maybe an hour, and I'll see you again, in 6 months. That's not the way that I work. Now, not everybody has to work that way. Sometimes you can basically collaborate with, psychiatrists can collaborate with other kinds of therapists, other kinds of programs and so forth who can continue to shepherd people along with those particular goals.
And they've got that real-time exposure to their clients so that you get the information, right?
Right. But I do. I collaborate with many of those other kinds of resources, especially people like you, and the kinds of things
for which we are grateful.
Yes, and not as grateful as I am for you and what you guys do. But I'm always thinking ahead. I always want I'm kind of like a coach, if you will, who is expecting a little more out of their athlete. What's the next level? how high can we put up the jump bar next? Can we raise it another inch? And kind of looking ahead, not just to what my patients have accomplished so far, but okay, where do we go from here? Back to Latin, quo vadis, where to go from here? So I'm really dedicated to participate. That's the way I like to work. That's why I went into psychiatry. I didn't go into psychiatry just to prescribe an antidepressant, make sure that you're sleeping and eating and have your energy and have your sex drive and all. Okay, next. That's people, and there's a role for that, I suppose. But if a primary mental health treater isn't doing that, then you need to add on additional resources to begin to tend to those other phases in this journey of success that we've been talking about.
Yeah, the saying this is a marathon, not a sprint, applies quite well to the scenario involved in mental health recovery. Now,
although I do want to say that it's going to require periodic sprinting, though. Right. I mean, in some of the more severe illness, correct. I mean, there's one step backwards, two steps forward. And when they take the step backwards, that requires a sprint to be able to return to the marathon.
If you end up needing the hospital, it feels like a sprint for sure.
Right.
And, of course, my experience with parents of usually parents of children, sometimes it's a spouse or partner or a sibling.
And you typically work with adult children, right? Parents of adults.
We cover a full range. I do primarily adults and focus a lot on older adults these days, which is why, you get a family that calls you and their son or daughter's 35 years old. And they've been struggling for a long time. They've gone back into the hospital, and this question comes up a lot because, families have been through what I call the gauntlet: multiple hospitalizations, failed treatments, apartments torn up, and cars wrecked, and even jail sentences and things like that.
Yeah.
They want to know.
I was going to say, welcome to my world, but we're both in the same world.
we live in the same world, or at least aspects of it for sure. And the thing that I get why they want to know. I get why this is important to them. First of all, they want to know if recovery is possible. I think you and I would celebrate and join in the answer that yes, recovery is possible. At different levels, people can achieve and sustain, not just recovery, but fulfillment.
And let's
they're like
the difference between recovery and cure.
fulfillment.
and
Yes.
cure, right?
Yeah.
I mean, these major mental illnesses that we're talking about, they're chronic diseases, right? So the outcomes are not typically cures. They're significant improvements, a well-managed stability, well-maintained life, and a maximization of the potential within the limits that the condition may impose.
Right. And so they're like, how long is it going to take? When does, and maybe this is the place where you can provide some insight that is what I try to tell them, let's find the right thing to do and let's do it for long enough. Because everybody's answer is a little bit different. But in your mind, you live on that side of the world where crisis and urgency is happening. You're staying involved with your clients at levels that I would hope to see as many psychiatrists out there in the world emulate. You set the gold standard, in my opinion. When you've got folks who are in long-term recovery, like sometimes it's not a timestamp. Sometimes it's, like you say, these domains, if you will, of recovery. They've got a job. They've got the license back. They've gotten these things, these aspects of life. In your mind, what is this marker where it's like, the comparative analogy is when a kid's learning to ride a bike, when you can let go of the bike. When a person's in mental health recovery from a fairly acute condition, in your mind, what are the markers that say, hey, this person might be ready to do this on their own a bit? We can. It's not that we can't attend to this illness anymore. It's more that as parents, I can sleep at night. I can breathe a little easier. They're looking for this relief. It's like, where is this place in the future that could exist, and how do we know that it's happened? What kind of answer would you give to a parent asking you that kind of question?
Yeah, well, I think it depends, and it depends on sort of what are the specific nature of the problems that the person is having. I think that I think most people recognize the difference between an acute exacerbation and an acute illness, right? And a much more, stable phase, although it might involve different levels of functioning. I think it's very important for thinking about parents that the healthy developmental trajectory of all organisms, human beings included, uh,
Right.
is separation and individuation, right? So
Right.
we start off literally as part of our mothers, right? Uh, and we gradually grow away from mothers and with fathers or father substitutes figures help. Doesn't even have to be male. Um, and, gradually achieve independence. Unlike many other mammals, our phase of dependency is very, very long. It's not like a calf who can get up and stand on its legs, within a matter of hours. It takes a whole year, to start to become a toddler and begin to even start toddling away. Plus, having to be acculturated in our incredibly complicated society requires a long period of independence and education and guidance and mentorship until people are launched. And especially as society becomes increasingly complex, we're seeing that period has become more protracted. There's now sort of a new phase of development that's we're coming to recognize, at least in the U.S., of sort of early adulthood that maintains a lot of still dependency parents financially, sometimes residentially, based on the state of the economy and
Hmm.
other resources that may be increasingly hard to get, um, as well as frankly sort of the general tide of mental health that characterize our youth these days, which I think is not quite the same as it used to be in their parents' and grandparents' time, probably for understandable, legitimate social, societal reasons. Uh, that make the world, a much more difficult place to navigate than it used to be.
I have one of those residentially dependent young adults. So,
Yeah.
so I know what you're talking about.
Yeah, and I'm in the last phase of that, with my
Congratulations.
with my 27-year-old, right? So I think that so parents certainly need to allow for the fact that there's a normal trajectory there, but to always be keeping a thought out for how independent and self-sufficient is a person able to be, and to try to create opportunities for maximizing that when possible, little by little, and not giving in to the temptation, the understandable parental temptation to make it easy as possible for your child. I mean, there's a thin line to walk there. There's a Goldilocks zone, if you will. Not too much,
Right.
not too little, right? Just right. In which, making opportunities for self-sufficiency, not driving your kid everywhere, not paying for everything, not, tidying up the room, for your child to have, expectations and consequences, both rewards as well as consequences, that you build in for independent behavior. And I think that as you gradually help your adult child to move towards increasing independence, you will begin to get the proper sensation that all parents hopefully are eventually able to get, that your bird can begin to fly a little bit. And it's not an all at once thing, right? It's a gradual thing. And it may only be able to be limited in a way. So I think one of the things that's especially important at a certain point is to start to think, because, we parents, we're not going to be around forever. So we have to start to think about, all right, if we're going to need to be involved, how involved do we need to be, and what is the succession plan? So one of the things that I often have to really push families for, and I do work with families, is let's think about a little bit more independence in residence, to be able to see if we can move your adult child into a situation that's not a huge step, like going off to live alone in an apartment by yourself. It's often not the next step, if it's even an eventual step. But let's get you into a supported living situation, a situation where, if at the least, we can have drop-in case management come in, or a group residential situation, or a therapeutic community, that the kinds of which you're very connected to, but to begin to move their offspring along in that level of self-sufficiency, because depending on a case manager or a residential treatment staff is a step forward than depending on a parent. And that you might say, well, what's the difference? They're going to depend on me and they're going to depend on them. And isn't it the same thing? It is not the same thing, because the inherent gravity of regression that happens with the parent is something that, is endemic to the parent-child relationship. For all parent-child relationships, forget about whether mental illness is involved. I mean, when I go home, my mother, is worrying, am I wearing, have a sweater, picking lint, off my shirt. She falls back in, to the role of mothering me, my food and things like that. So, I mean, that's endemic to the parent.
Love that expression, the gravity of parental
gravity of regression.
It's gravity of regression. My goodness. Well, and I'm really glad you bring it back to kind of stages of natural development for human beings, um, and looking at whether they've got mental illness or not, you're looking at it from the standpoint of let's give them opportunities to express independence and a little bit at a time so that they can get accustomed to it and not be what they call now the lawnmower parent, which is to
I'm,
mow everything down out and get out in front of your child and mow everything down so they don't have any.
I've heard helicopter, haven't heard lawnmower. That's
The
useful.
lawnmower parent, that's the new one. So at any rate, when you've got a child who suffers from mental illness, of course, and I'd love to know, I have what I say, and I think you and I look at families in very similar ways. Uh, One, compassion as a parent, and two, compassion as a parent who has a child who's suffering from something. And there's a lot of this reasoning that, well, I don't want to let them go. I don't want to kind of give them these chances at independence, even though they're mild ones, even though they're really probably going to be successful at it, because what happens if? What happens if they fail? What happens if, because what's happened if they failed in the past, obviously, has been, maybe they end up in the psychiatric hospital, or they've got these things that it's pretty disastrous what's happened. And yet it's still important that they take these steps. How do you give parents comfort when they're asking about this kind of tension they have in giving their child stabs at independence so that they can become better?
Yeah. Well, I think every parent remembers uh, helping their child learn to walk, right? And seeing them fall down and get up and have maybe the skinned knee and so forth.
Mm.
So we all, as parents, have had experience with stumbling and failing. So we're not new to that challenge, uh, even in these very complicated, more adult situations. So I think first, bringing people back to their experience, their competence that they have, developed in earlier stages of development, can help them grasp the essential ideas here, and to see that they themselves are capable of tolerating some setback, some fallback. Uh, Secondly, I think that I like to often I take my whiteboard and I draw on the whiteboard uh, two figures. One is this smooth parabola, and the other I draw is a jagged line that goes up. Right?
Squiggly line that goes up.
Right. And I say that first figure is physics. The second figure is biology.
That's
Right.
great.
Right. Physics, and although I guess if you look at the micro level, the baseball is bouncing around a little bit through the air, but for the most part, it's a much smoother trajectory. Uh, but biology is inherently variable, and in fact, that's part of the strength of biology, is that we're built to have a certain amount of resilience against environmental perturbations, so that it's part of what it means to be warm-blooded, right? The temperature can go up a little bit, it can go down a little bit, right? The blood pressure can go up a little bit, it can go down a little bit. That kind of dynamism is actually part of the adaptive nature of biology in general. Sometimes when I do that, and by the way, when I draw the squiggly curve, I show it going up, right? And I say, this is, think of the stock market, right? The stock market, which by the way is a biological phenomenon, right? It is a epiphenomenon of human beings and human activities and human minds, right? It's not a phenomenon of physics or geology. It's a biological phenomenon. So I, let people understand that some to and fro, some steps forward, some steps backwards, is actually normal. It's a normal part of living and of being alive, so that you don't want to control things. so tightly that because what you're expecting is your loved one to be a baseball, right? Rather than
Some perfect projected version of development, right?
a living being that, having bad days, having setbacks, having bumps in the road, whatever metaphor you want to use, is actually very important because we all experience them, and you need to let your loved one being able to experience some of that, which means how to, contain your panic when you see this isn't a good day compared to yesterday. So how to distinguish the difference between bumps in the road and true, authentic relapse is one important thing that we talk about. And so allowing people to have some to and fro, and to be able to look at the big picture and not to examine your loved one with a microscope. How are you feeling today? How are you feeling tonight? How are you feeling today compared to this morning?
Now, right.
Right. How are they behaving? Now, let's take a look at the trajectory of, weeks and months and even years. So to have a more high altitude look, just like, you shouldn't watch your stock portfolio too closely, right? Right. You need to have the big picture. So that's another principle that I utilize in terms of this. And I think that to also uh, recruit your loved one into the vision of progress and independence, because I think that in everybody, even if you're ill, even if you are dependent, I think there is a natural inherent force of growth, a natural inherent instinct towards individuation, right? And so to really ally with and collaborate with your loved one about what are they wanting as sort of the next level of self-sufficiency and independence, and to negotiate that with them and to have choices available for them, I think is quite important. And then finally, I really do think that the most optimal treatment for people with serious major mental illness is to have, if possible, and I think everybody should be working on their loved ones to make it possible, to be in a collaborative relationship with the treaters, to be able to
Indeed.
have an open communication. I mean, I don't talk behind my patient's back, but I mean, just today, I had a big family meeting with a wonderful young man with severe schizophrenia who's done marvelously. But I had the parents in to talk about, what our progress has been and so forth. And we have an open door, and they know that they can let me know if they have concerns. If necessary, from time to time, we may have to have a meeting together as a family, if not just to check in, sometimes, to deal with setbacks. So I think that knowing, for parents to know that they have support from the treatment team or the treater is really optimal, as well as other supports, peer supports such as National Alliance on Mental Illness, and for their support groups for families and their family to family course, which I'm happy to say most of them now actually have my book on their bibliography list for the families, because that's a context in which the need for that often comes up. So in having the wisdom from other families that are struggling with some of the same things, and to have that kind of support system is also very important. So other people who can hold your hand, so to speak, when you start to
Right.
get panicky, that things are going off wire.
Well, and right after I send people a copy of your book, of course, I send them, a link to wrap planning, which I'm sure you're familiar with. But, in short, it's a mechanism for saying, hey, what does your life look like when it's going well? What does it look like if things are starting to shift or you're having some issues or symptoms again? And if it gets to a certain point, what do you want us, your family, your loved ones, the ones who are close to you? How should we support you? And what do you want us to do about it?
Well, that's the whole philosophy, if you will, of advanced directives.
Of
Right?
course, yes.
Which, by the way, in some jurisdictions is actually has some legal teeth to it. I mean, we have in Maryland, we do have a mental health advanced directive, where when you're well, you can specify what you want to have happen if you get ill again. Yes, I would like to be forced to take medications and so forth. Uh, you can rescind it, but there's a certain waiting period, if you want to rescind it. So you can't just rescind it on a dime. Some states, some jurisdictions have some legal infrastructure for that, but at least on an informal basis, to do that as a family, I think can be very helpful. Do you want to say for the listeners here what that link is for that
Oh
kind of
yeah,
advanced planning?
WRAP, RAP plan. You can, if you Google that, I'll put a link in the description, of course, so that people can follow it. But Wellness Recovery Action Plan is the name of
Mhm.
and you hit Google and it'll give it to you pretty quickly. So,
Good.
um, but again, I also, and then this is not flattery. I definitely send many and multiple families copies of your book. Mine recently got damaged, so I'm going to need another signed copy if you don't mind.
Absolutely. I'll put it in the
But
mail later today.
right, but the I think that the biggest challenge for a lot of families, and this is especially true, so something I'll get you to give a final comment on here. Families who are experiencing acute psychiatric symptoms with their loved one, probably a child, for the first time. And this
That's
is,
very scary.
there's this grand disillusionment that happens. So, you know, even today with a family that's been going through this with, almost a decade with their family member, well, 8 years. And, I said, look, he's coming home from the hospital and he's going to go into treatment and everything else. Don't bring him back home. They, because it's just like you say, the gravity of the dependence is real, and it's just the person goes right back into the same old thing. This is the time for this individual to launch. And mom comes back to me. She says, I know what you're saying is true, but it was heartbreaking and so hard to hear. When you've got families that are experiencing their loved one's a young adult, they're having psychiatric symptoms, they've gone for their first, psychiatric hospitalization. It's clear that they're suffering from, say, schizophrenia or bipolar disorder with psychotic features or delusional thoughts. What comfort do you try to offer them at that time? It's a terrible situation for anybody to be faced with, but as a doc, you've done this so many times. What do you say?
Yeah. Well, I first of all, I remind them that this is an illness, and like any illness, we have 21st century state of the art treatments for this. And sometimes those treatments can be remarkably effective. Just as if, if we were talking about, your family member having cancer, right? Now, obviously, nobody can guarantee any, an outcome, but we can be very optimistic that we have so many different tools at our disposal now that we didn't have even 20 years ago, let alone 50 years ago, that can really create a very, very good outcomes. Secondly, like any disease, some diseases have better natural histories than others. Some individuals have better natural histories than others. So we don't have to think of worst case scenarios. Just like with a cancer, we don't have to think about the 20% of people who don't live more than 5 years with this, right? We can look at the 80% of people who, are doing fine at 5 years. So let's not, let's not hang the crepe for this one particular person until we've had a chance to see what is the specifics of their illness manifestation and what kinds of state-of-the-art medications and other treatments, not just medicines, of course, therapies, rehabilitation, resources can be brought to bear. So there's always a lot of hope. Also, the earlier that you can get started with these things, the better.
Yeah,
so for
absolutely.
first breaks, I say, well, the good news is you guys have gotten here, at first, as early as possible. I've had some people who didn't show up for treatment until, they've been ill for 15 years. And that's, the prognosis is much different when you allow these things to smolder for a while and indeed kindle for a while, like a fire, especially for things like bipolar disorder. The more relapses you go through, the more severe those relapses are, the more frequent those relapses are, the longer the relapses will last, and the less responsive they are to medications. So, and kind of like a fire, it starts to burn at the edge of the curtain, and the longer you let it burn, pretty soon, the whole curtain's
It's
on fire,
engulfing
the ceiling's
things.
on fire, and you're into a 5 alarm fire. And by the way, I talk about this with patients very early on about kindling, about why getting with treatment and sticking with treatment can affect the entire course of this disease for years to come. That and we know this is a relapsing illness, and if you stop the treatments of various sorts and let this relapse, that it's going to grow, it's going to kindle. But the good news is that you can minimize that. You can change the trajectory of what's going to happen for the next 3 decades by what you do now early in the course of the illness and sticking with it. So that also, gives you a sense of control, some control over the future. So I explain that to patients and their families.
And I had this another client, and this is just this past week, and they wanted to maintain and say, well, every time this happens, he goes to the hospital and things go terrible and so on. Eventually, he's going to get the point. Like eventually, he'll learn that his pattern is one where if he doesn't stay on his medications, take care of his health, he ends up here. And I said, actually, it's quite the opposite. Largely, it gets worse. It doesn't get better because the longer they go in, it's like setting the brain on fire. And the longer they go untreated, the insight doesn't get better. It gets worse. And the brain doesn't catch on. The delusion gets thicker and persistent and everything else. I said, you've really got to, if you can, take care of this as early as you possibly can. And with sustained treatment, and consistency on not just medications, but all the other care components that a person should engage in after a longer period of time, that's when they start to get it. They start to not want jeopardizing their life, community, and friends and family and jobs and other things. And jeopardizing those becomes more important. It becomes that's the important thing to them. They wouldn't jeopardize that, whereas before they had nothing. There's no consequences because they have nothing because they don't have any stability in their life. So at any rate, it's a tough message to give to parents.
It's not a mere tautology to say the
Right.
longer you can stay well, the longer you can stay well.
That's right. Absolutely. It boils down to the most simple phrases, doesn't it? Dr. Komrad, it's just a pleasure to talk to you and hear you and your years of experience speak. I'm so honored to have you on the show and return to the show. I hope that you can we just continue this conversation and you can join us again. You're not on the let us know where you are, if you're going to be on the radio again or you're going to be on TV again or at least a demi celebrity at this point for sure, So let us know where you are.
A legend in my own mind.
But I thank you so much for being with me today. This has been Head Inside Mental Health with Todd Weatherly. Dr. Mark Komrad joins us. Dr. Mark Komrad, thank you.
Thank you so much. I always enjoy talking with you, Todd.
And we'll see you soon.
Thank you for all that you do for me.
You're welcome.
I feel so lonely and lost in here. I need to find